Welcome, everybody, to Innovating Healthcare by Chamber for today's special episode for World Cancer Day. My name's Byrne. I'm the Director of Advocacy for Macmillan Cancer Support, and I'll be chairing today's panel, which will discuss some of the biggest issues facing patients and cancer care in the UK today. If you want to join the conversation, be sure to use hashtag Innovating Healthcare on Twitter to let us know your thoughts on today's discussion. We've got a fantastic panel today who I'm delighted to be able to introduce. First up, we've got Chris Bryant. Chris is the MP for Rhondda. Following his own experience with melanoma, Chris has been particularly vocal on the need to address the shortage of radiologists and pathologists in the UK. David Long leads MSD's oncology operation in the UK and has a wide range of experience working in health systems across Europe, as well as a background leading on vaccines. Dr. Jeanette Dixon is the president of the Royal College of Radiologists and has a strong clinical interest in the multimodality management of thoracic malignancies. Yosh Cook is the Programme Director for DataCan and is passionate about enabling better decision-making through unlocking the power of data to drive healthcare forward and positively shape the life sciences industry. And last but not least, we have Professor Mark Lawler. Mark is Associate Director of Health Data Research for Wales Northern Ireland and also works with Yosh as the Scientific Director at DataCan. So thank you, everybody, for coming. What a fantastic range of expertise and insights we'll have today for our discussion. And we're meeting on World Cancer Day, and quite a timely opportunity given that we've heard some big announcements today from the Secretary of State for Health and Social Care in England. The Secretary of State has launched his vision for a new 10-year cancer strategy in England, with lots of big ambitions set out there, including a focus on new technologies to improve early diagnosis, intensifying research on mRNA vaccines, tackling inequalities and improving prevention. So perhaps we could start by reflecting on what we've heard today. Chris, I wonder if I could come to you to begin with. Given your personal experiences of cancer, how did you respond to the news today, and how do those priorities feel to you? Are those the ones you want to see in a new 10-year strategy?
Well, I've been in a school all this morning, so I haven't the faintest idea what Sajid Javid has been up to. And he's the Secretary of State for England, and I'm an MP in Wales. So I'm probably the least useful person to speak to about this. But I have three things I think that matter in this world. One is early diagnosis saves lives. We know this. Early detection. If I'd left it another month, my stage 3B might have been a stage 4 melanoma. And as you know, there are only 4 stages really. And whilst medicine has advanced dramatically, that might have been the difference between life and death. I'm conscious in my patch here that bowel cancer, in particular, men present very late. It may be that COVID is going to lead to more numbers of people presenting late as well, so that's a real challenge in the short term. There's a massive. My second point is about the workforce. We aren't training enough pathologists this year to meet the number who are leaving this year. So, and that's without factoring in an increase in the population. And by pathologists, I mean that or the whole set. And then thirdly, just about it is a fact, a simple fact, that medical advance always leads to dramatic inflation. So just going back to melanoma, NICE had licensed immunotherapy and targeted therapy. I had targeted therapy, mine was BRAF positive. 2 weeks before, in an adjuvant setting, 2 weeks before I presented to my GP. Hurrah, it took my life chances of living for more than a year from 40% to like 85%, 90%. NICE is considering at the moment adjuvant setting for stage 2 melanoma. that's, it's £100,000 a person, isn't it? But it will save lives. My guess is they'll end up allowing it. So we are going to have a national discussion with ourselves about how much money we put into the NHS. Those are my three things.
Thanks, Chris. Quite an important three things, I would say. I wonder if I could pick up on the point you mentioned there around workforce, and that feels particularly an acute challenge at the moment, not least given the impact of the pandemic on the workforce, the fact that we were already facing a workforce crisis in the NHS before the pandemic hit. And now, of course, we've got a really depleted and exhausted workforce. Jeanette, I know you're particularly interested in the recruitment and retention of radiologists, but I'm interested to hear your perspectives on that workforce question. How do you see us moving forward on this challenge?
I think you're right, Eve. I think the pre-COVID, the workforce was not enough. And post-COVID, we know that a lot of people are, due to stress and due to tiredness and due to exhaustion, are reevaluating their work-life balance and are pulling back and leaving the workforce early. So I think you have your immediate things that we need to do. We need to retain the workforce. We need to make them feel valued. We need to employ flexibility in their contracts. We need to allow them to have a better work-life balance. All these things exist. They are able to be done, but there's a lot of hesitancy on the part of employers sometimes, or hesitancy on the part of departments to invoke what is there. So we need to be flexible to retain people. We need to make the workforce feel valued. We also need to try and perhaps train extra groups of people. We have skill mix in this country much more than anywhere else, partly because we don't have a big workforce. So we train radiographers, we train nurses, we train pharmacists to take over other roles that doctors do. And I think we need to maximise that. But those workforces are in shortage as well. So it's this robbing Peter to pay Paul. I think we need to think about global recruitment. That's a tricky one at the moment. And it's also ethically tricky as well. Why would you divest a country which has a poorer healthcare system to bring people to the UK? That doesn't always sit well. And I think we need to train more. I think Chris has hit the nail on the head. Workforce is a huge issue. We are the president of the College of Radiologists. So we do radiologists who are the expert doctors who interpret imaging. So your CT scan, your MRI scan is interpreted by an expert. We are about 2,000 whole-time equivalents short in that situation. And I am a practicing clinical oncologist, so I treat patients with cancer with both systemic therapy and radiotherapy. We have a 17% shortage in our workforce of about 189 whole-time equivalents currently. We're not training enough to meet requirements. We're not training enough to meet the demand. The demand is only increasing because of the population aging, but also because of the need for more complex imaging. So across the board, the workforces are very short, and we need to recruit more and train more. Fortunately, there are enough doctors who want to do both oncology and radiology. We have a pool there. We just don't have the finances to do that. But we also need to think about the other workforces. We need to think about radiographers. We need to think about nurses, and we need to think about pharmacists. And we also need to think about the kit, because you need to, if you want to scan more, you need more scanning machines as well as more doctors.
Absolutely. Thanks, Jeanette. And I think that comes back to the point Chris started us off with, which is, and to do all of this, we're going to need resource. And you talked really clearly there around the challenges facing the workforce. And I would add to that from Macmillan's experience. Obviously, we fund thousands of cancer nurses in the NHS across the UK, and we've done the modelling, and we know that we're facing a shortfall of 3,000 in the coming years. And it's really difficult to see, despite grand ambitions and speeches made by politicians committing to expanding the workforce, where those costed plans are coming from. We haven't got the modelling being done at a central level to help inform that conversation to even understand the requirement. It's falling to organisations like Macmillan and you and the Royal Colleges to really understand that picture. And one of our concerns is there isn't that central modelling happening. Mark, I wonder if I could bring you in here, because obviously this is having a huge impact on the patient. And we know that when cancer patients are not getting that holistic and rounded workforce support from a multidisciplinary workforce team around them, that can have huge impacts, not just on their experience and all of the unnecessary stress and anxiety that could bring, but also on their outcomes as well. I know you've done a lot of work with patients and on patient voice. So I wonder if you've got any reflections on how this is coming to bear.
Thanks very much, Eve. No, absolutely, critical. One of the hats I wear is as the co-chair of the special network of the impact of COVID-19 on cancer for the European Cancer Organization. And we looked particularly at workforce, but also then the patient experience and also patient surveys. And what we found in relation to the workforce was, and this is specifically for cancer, 4 out of 10 cancer health professionals are essentially burnt out, and 3 out of 10 are showing signs of clinical depression. And that's data that's collated from across Europe in a study that we did recently. We also then have looked at patient surveys that patients have done themselves, number of ones, particularly good one by the International Brain Tumor Alliance. And that shows the fact that patients really need that multidisciplinary support. We talk about remote consultations being something good that came out of the pandemic. Sorry, nothing good came out of the pandemic, I'm sorry to say. And really, the idea that remote consultations are going to be the panacea for everything is not true. We're going to have a mixed model that involves both remote consultation, but also interaction face-to-face between patients and their multidisciplinary team. The other thing we've really found is that patients have to be active participants in the process and not passive recipients. And I don't see much in the new cancer plan in relation to the patient being involved centrally, not just lip service, not just token, not just tick box, but actually involved in co-creation. So certainly I'll be pushing the Secretary for State to show what is the plan of the patient involvement in this. What we don't want is just to have a technocentric solution and not a holistic solution that actually is what patients need. Particularly, and obviously very well in relation to Macmillan, we need to be thinking not only about cure, but also quality of life. And we need to balance those two with each other. And it's really important that we do that, and that needs that patient perspective. I'm a big believer in data and data intelligence. And I think one of the things we need to be doing is using data intelligence to drive our decision making. Too often in the past, we haven't done that. We haven't collected the data. You said yourself, data modeling hasn't been done centrally. And so therefore we're making decisions. We might as well just be putting our finger in the air. And we really need to be using data intelligence to drive our decision making. If we don't do that, we're going to make wrong choices that won't benefit our patients. And the other thing is that we have to remember that the impact of the COVID pandemic has actually been catastrophic on both cancer services and cancer patients. And sort of going back to the old normal is just not good enough. We've estimated in DataCan you probably need to be working at 130% of capacity, but that 130% needs extra resource to drive it. It's particularly, as I've already said, and as Jeanette has said, the workforce is burnt out. We're not going to be able to then suddenly come up with 130% of what they're doing. We're not able to do that. So there's really needs to be looking at ways in which we can critically assess where are the pressure points, where do we need to invest properly, and not simply go after the latest fancy therapy.
Absolutely. Thanks, Mark. I think that's such an important point in terms of that dual focus. Yes, on research and innovation and treatments to improve outcomes and improve survival, which we've heard a lot about today.
I quite like my fancy new therapy.
Yes.
Thank you very much.
Very important.
No, but absolutely, also, Chris.
But we'd also like the workforce to deliver it safely, and the workforce to have the ability to roll it out safely and rapidly.
and to support the patients in receipt of those treatments, to understand their options, to understand the treatment pathways available to them, the risks. You know, we know from our experience in Macmillan that a cancer nurse specialist can make all the difference between whether someone turns up for their appointments or not. So absolutely, treatment and the emphasis on improving treatment is so important. We have to have the workforce there and that focus on the patient's experience if we're going to see that transformation that we all want to see. Yosh, I wonder if I could bring you in on this, because I think there's also something here around the patient experience when it comes to, we've talked about how important that is when it comes to understanding treatment options. Obviously, there's a lot of talk around clinical trials and access to clinical trials and embedding that research in patient care. And what do you think are the biggest barriers at the moment to kind of, I guess, ensuring that we have the access for patients that we need to see on an equitable basis for clinical trials and research?
I think what you're asking here is the actual golden ticket, isn't it? I mean, I firmly believe that we have to learn from every patient's experience, and that's how the ecosystem needs to really kind of come together here, powered through, you know, the workforce, incredibly important, but powered through data and technology to really democratize that access. So, you know, every patient's treatment is incredibly important to that individual patient. We need to surround them with the right level of care, but let's learn from how that patient felt through that experience, whether they experienced different outcomes versus others, not just the pure, what I'd call the pure clinical outcomes and measures, but how they felt through it. And as I said, I think, you know, data and technology, real world data really does have a role here. The real-time nature, and, you know, I'd echo what Mark said, nothing particularly great came out of COVID, but the whole importance and the push towards real-time or increasingly real-time understanding. You know, we are a data-driven sector, and we need to take the latest data to inform going forward, not just kind of data that potentially was collated a long time ago on various different kind of patients. Coming to your point about the, you know, trials, you know, trials are incredibly important to get innovative therapies and options to patients, particularly in cancer in the kind of more advanced stages and everything. And I have to say, you know, the UK experienced a very kind of faster uptake, particularly through COVID. We overcame a lot of barriers that I think were existing through the system, and I hope that those barriers continue to be suppressed as we go forward and even removed kind of longer term. You know, one of the kind of key challenges, I guess, is really finding these patients. We're after, particularly in cancer, increasingly niche patient populations. How do we find these patients who are potentially eligible? And these don't always sit in these large cancer specialist centres. They can be in any centre, small DGH, for example, in any part of the UK. I'm personally massively passionate about making sure we democratise the access to these innovative therapies. I don't think you should have a different level of care based on where you live or where you are treated or happen to be treated in the country. So being able to put some form of data and technology at the centre to allow data to flow, I think will be really key. So keen to see where that falls in this war on cancer that's been announced very recently. You know, I think we can't have lots of different point solutions. It needs to be all tied up as one, really.
Really important thoughts. Thanks, Yosh. And I guess a question that comes to my mind here when you talk about the challenges of reaching different communities and what are the solutions to help with that? Do you think there's a role here for partnerships with charities, voluntary sector, community groups? Obviously, Macmillan is very keen to play our role here if we can help.
Yeah, completely. I mean, I think, you know, as a sector, we've got some very big challenges, and that doesn't come by each of us trying to squirrel away and looking at how we can solve for these. And, you know, I'm very happily part of DataGAN together with Mark. And it's a great example, as are the other hubs, of ways in which different organisations across our industry can come together. We've got academics, NHS, private research organisations like IQVIA, all coming together to work out how we can build towards this. Charities, the patient voice is incredibly important. And I don't know if Mark wants to come in here about the patient voice. We're very, very strong within DataCan. Very proud of it as well.
Yeah, no, we've been really lucky in terms of we've very much empowered our patient group, and not only are they empowered, but they feel empowered. We published a piece, I'll put it in the chat in relation to that in BMJ recently. And that's really critical, that co-creation part that both Josh and myself have highlighted, because it means you're working together on real solutions that patients want the answers to, and not esoteric solutions necessarily. And that's really the focus. And I'm sorry, maybe I misphrased myself earlier when I said fancy therapies. I'm very much a proponent of innovative therapies, but what I was trying to say was that it's important that we focus on what are the needs of the patients in relation to the development of those new innovative treatments. But certainly, we work very closely with our patient advocacy group. They're on our steering committee, on our management group, they're on all the subgroups, and also then they're involved in any of our contract negotiations. They're involved in sitting on our boards when we hire people. So it's, it's all encompassing, and that's the way it should be.
Thanks, Mark. Some really important reflections there. And Jeanette, I wonder from a kind of perspective from the work of the Royal Colleges and the workforce here, whether you've got any thoughts on ways we can reduce those inequalities and improve access.
I think trials provide a really, really good vehicle for improving access across the geography, because let's not argue about what good came out of COVID, but at the start of COVID, we wanted to reduce the number of people coming to hospital, reduce the treatments as much as was safe. There was a trial just about to be published in breast cancer, which showed you could reduce the number of treatments from about 4 weeks to about a week and a half. We were able to change overnight, essentially between March and April 2020, we brought that into 80% of centres, but those centres were the ones who had taken part in the initial trial. So they had the quality assurance, they had the safe access, they had the knowledge to do it. So patients do better who are in trials. So by definition, if you expand your trials and you expand patient access to trials, you improve patient care, but you also encourage that innovative rollout. And therefore, the infrastructure for trials is a really important way to improve access across the geographies. And that's true for radiotherapy, but it's also true for drug treatment, surgery. It goes across the board. And I think it's another thing about the workforce needed to support it and the infrastructure needed to support it. But it's a really obvious way that we have already that you can accelerate access.
Brilliant. Thanks, Jeanette. David, I wonder if I could come to you here, because obviously there's a really critical role for industry in improving access and outcomes. What role do you think industry have to play here?
Thanks. I think I'll maybe just pick up on the point on trials. I think it's a really important one, because I think what we see with trials, whether they're in therapies or in diagnostics or other elements as well, they help establish pathways. And I think some of the challenges we really face at the moment are really related to pathways, how they connect together, the different groups of people that work across the pathways in different sectors of healthcare. And these are really, really different tumour by tumour. So I think I completely agree. The more work we can do for trials, I think it really starts to lay down foundations for robust pathways going forward. I think industry can play a key role in that, naturally. I think there's also some work we can do in really sharing best practice across the countries as well. We see areas where things go very, very well from a pathway perspective. We see really great collaboration across, NHS, charities, industry, to really help support develop and improve pathways. And there's a key role industry can play, I think, in helping sharing some of those best practices, because we do see quite big differences across the country in terms of outcomes, across just not in terms of survival for cancer patients, but also in terms of how quickly they can get access to new innovations, whether they're surgical or medical as well. So I think that there's something really important in that. I think we have seen some good stuff from COVID that's come from the level of collaboration that has really increased across the different sectors, which really should be, I would welcome that. And I think there's a lot to build upon going forward. And I think we are quite privileged, I think, in England and in Scotland as well, in having pretty good access to innovative therapies. When we do look across other markets in Europe, I mean, we're in a good spot, and nice for all the challenges that often are laid at their door should be applauded for the speed they can work, and particularly through COVID, the speed they did work to review and get innovative treatments through. So there's a lot to be said there, and I think there's elements that we can take from everything over the last 2 years and look at going forward. And I think back to Yosh's point on data, I think this is something critical where collaboration can play a big role as well. And I think that's something we did see through COVID. The availability of some key data, wait times, for example, was just a lot more apparent than it probably was before. It became something very important for people to be paying attention to. And we've actually seen that really pull through to the pathways where they're just much more aware of, we may hit our 2-week wait, which is great. So patients get that referral in, but what does it mean in terms of them getting assessed and getting on to a treatment as well? So there's a lot, I think, just so much to be said for the collaboration that can happen across the different sectors to really support those pathways, which, if we can improve those, I think will ultimately improve outcomes for patients going forward.
Thanks, David. I think you've touched on a really important point there, which is capacity in the system. And we know that, of course, the pandemic had a huge impact on people coming forward with suspected symptoms. Now we're seeing a welcome change in direction there, and referrals are starting to increase. They're still not where we would, of course, want them to be. But as those referrals are increasing, we're not always seeing that subsequent increase in capacity on the treatment side. I'm just interested in whether the panel has any reflections on some of the solutions that are being considered at the moment, whether that be the use of independent sector capacity to bolster capacity in the system. The rollout of the Help Us to Help You campaign is obviously really welcome in encouraging people forward. What else do we need here to ensure that we've got the capacity to meet the demand that's coming into the system?
If I might, I think the point that was made earlier by Mark and by Jeanette is really important about trying to enable more people who are presently thinking of leaving to stay, enabling some people who have already left to come back, because we really do have to ramp up capacity very dramatically if we're going to tackle the backlog. And one of the things I've tried to suggest quite often is, I think I know dermatologists who haven't done any dermatology for 2 years. They've been working in A&E basically, or in ICU. And some of them, really what they want is a 2-month sabbatical. They just want to recharge the batteries. They don't want to leave, but if they don't get that, they will end up leaving because they're just knackered. So I think we could do something there. I think we still need to do a lot more of recruiting patients into the process of their own diagnosis and treatment and so on. I'm conscious that it's terribly difficult to hear a cancer diagnosis clearly. Terribly, terribly difficult. And clinicians have said to me, the thing is, all I'm thinking is, I just want to get on with the treatment and see the next person. Whereas actually part of the process of dealing with cancer is, as a patient, is it sort of has to, you have to absorb it, because everybody will have stories of people who haven't turned up for their second appointment or their third appointment or whatever. They're just too frightened, or they refuse to hear it, or they're in denial or whatever. And that could dramatically save lots of people's lives if we got that right. I think it'd be better if doctors, if consultants, instead of writing to GPs and copying patients, wrote to patients and copied GPs, so that it was in a language that the patient could understand and they'd take more ownership of it. And I hate this language of a war on cancer. It's preposterous Boris tosh. And I also hate it when people say, oh, he was a real fighter, he fought the cancer and he was so brave. So far as I can see, being brave and fighting hard doesn't make the blindest bit of difference to your survival rate. So I wish people would shut up with that language. And it would help if more clinicians would say that to politicians. I'll shut up.
It's a really important point, Chris, and we've done lots of research with our patient groups at Macmillan that tell us time and time again that that style of language is very outdated. It doesn't reflect how they feel about their own cancer experience, and actually it can be really unhelpful to them. I think it's a really important point around the importance of patient proofing our rhetoric around cancer, or what politicians say, and ensuring that when these plans and announcements do come out, they've actually been tested out with patients. Jeanette, I wonder if you've got any reflections or experience in how patients feel around this issue.
I think a lot of patients essentially have the same view that Chris has, because sometimes what you get at the end, you get this bit about, well, they didn't fight hard enough, so we're almost victimizing the patient for an outcome that is nothing to do with the patient. And I think the families often struggle to negotiate that. So I think it's you're right, it's a very old-fashioned way of looking at it. I'm very pleased that there's new investment in cancer. I'd rather it wasn't a war, because the bit about the war analogy is that at some point it will end, and I think there is an issue around there will be a victory and we will see a victory, and I'm not convinced that that's what we're going to achieve. I think we need to bring in patients, as you've said, Mark and Josh, really well about that co-production, because it's only with co-production that you get that the patient's understanding why you're doing something and beginning to gain from the treatment, but also to enable that treatment to be delivered in the safest way. And I think with Chris as well, I was part of the Academy of Medical Royal College group on writing letters to patients, and it's about the demystification of the language. It's about providing a language that everybody can buy into, and it's about giving the patients the information that they feel they need, because you're right, it takes time to sink in. So you need a record that patients can relate to, but also can go back to and can think about, I think.
Thanks, Jeanette. Mark, I can see you've got your hand up.
Just want to agree with Jeanette, completely outdated, and Chris. The last person who declared a war on cancer was Richard Nixon in 1971, and look what happened to him. So, we need to really get rid of that type of rhetoric completely. The other thing, just going back to what Chris said, and again, one of the things we did was develop a 7-point plan to mitigate the impact of COVID on cancer at European level. And number 1 on that list was getting rid of the backlog. But number 2 on the list was actually reassuring patients and restoring confidence in being able to go to the doctor, being able to go to the cancer specialist, being able to go to the clinic. I've just come earlier from a World Cancer Day event that I was hosting that is called the Time to Act campaign. So it's a pan-European campaign, essentially saying we need to act now in relation to addressing things like the pandemic backlog, but also looking at ways in which we can support patients, we can support health professionals. And it's really using those type of approaches. And yes, we also need to look at ways in which we can restore capacity. And I think we should be, willing to look at different potential solutions. I think it's really good to see the early diagnosis and the early diagnostics clinics being suggested. However, we were suggesting that pre-pandemic that they should be doing that. So glad finally they're taking on the message. In relation to treatment, I think we do need to look at capacity issues in relation to that, because we are going to see potentially more complicated treatments, because we're going to have people who, because they were diagnosed late, then their treatment is going to be, in most cases, more complex. So therefore, we're going to have to look at sort of specialism as well, and radiotherapy, as Jeanette had said. So I think and part of that needs to be investment, but also it needs to be looking at innovative solutions and using data to drive those solutions as well.
Great, thanks, Mark. Just continuing with the theme of inequalities, because I do think the points we're discussing here around that patient-focused approach, use of language, how we communicate is so important, particularly when we consider inequalities and the access issue that we've talked about. David, I wonder if I could bring you in here in terms of the work that's happening in reaching communities from who perhaps might be struggling to access care and treatment.
Yeah, I think just reflecting on some of what the health secretaries communicate at the moment, I mean, referring to the need for campaigns, awareness campaigns to help us help you, which I think is great. It's really good to get the message out there. But I think one thing we've discovered in collaboration with the UK Lung Cancer Coalition is trying to really understand a bit more about lung cancer. It's a very heterogeneous group of patients that suffer from lung cancer. From some very young people to obviously people who are more elderly with a lot of comorbidities and with very, very different profiles. So I guess one piece of work we undertook towards the end of 2020, coming out of that first acute phase of the pandemic, understanding the pretty profound impact in terms of patients not presenting to primary care, not presenting anywhere in reality into the system. So we wanted to try and do something about it, but we wanted to tackle it in a bit of a different way than a sort of a broad brush campaign, to be quite focused and quite targeted. So I think in collaboration with a load of partners, and it was a really good piece of work with different cancer alliances, with some charities, as well as the UK Lung Cancer Coalition as well. We put forward and supported some targeted efforts to try and engage with those difficult to reach populations in lung cancer. So some of the efforts we did there, we steered quite far away from the more novel social media mechanisms and really use more traditional means, radio, TV, bus adverts, and really, classic things like this to really try and get to different communities in different parts of England to try and see if a simple message on, if you have symptoms, please go and seek some help, would actually have an impact. So we did it in a number of cancer alliances. We did expand it through last year. And the initial insights and the data we've seen definitely do show an impact. We do see in areas where this campaign didn't run that the rates of referral are different. There are more referrals happening. So I think it just speaks to, it's great to have the broad awareness, but I think the question on language that came up earlier on is really important. It has to be very targeted to the communities and the people you're trying to reach. Otherwise, the message just won't land. So I think it was just, again, acknowledging the importance of that in this sort of the grand scheme of things, how local efforts, local collaborations to really engage with those communities are really, really important and can have a profound impact as well.
Brilliant. Thanks, David. Really, really great to hear about those different examples of innovation and experimentation, I guess, to see if we can find better ways of doing this. I think the pandemic has thrown up so many different innovations, and I think we're all agreed that we don't want to describe anything as coming good from the pandemic, but we did see those, chemo buses, in lieu of chemo being able to take place in cancer centres. We did see a real kind of focus on innovation and just getting things done perhaps in a different way. And I suppose, I know we've reflected on this already, that freedom, I suppose, that the pandemic also gave for clinicians to try things in different ways. A lot of clinicians reflected on how it was a period where bureaucracy and red tape was perhaps not as stringent as it is usually. I wonder if the panel's got any reflections on that and how we can take some of those best bits forward and build on some of those practices that did work quite well during the pandemic.
Maybe I could come in to start, Eve. One thing that I think, and I've sort of harped on about this a bit in different fora, we're able to get COVID statistics every day, data on numbers, deaths, vaccine. Why can't we get cancer data every day? That would really help us a lot in terms of making decisions, particularly in relation to both early diagnosis, but also treatment. So I think, I think a number of people in the panel have said at various stages the importance of data. I think we really need to focus on that and unlock the data, because we really have very good data in the United Kingdom, but the problem is a lot of the times getting access to it, to use it in a rapid and effective way, is often challenging. And I think if we could solve that problem, we would really go a big way towards addressing some of the challenges in relation to late diagnosis, quality of life, etc. So I don't see any reason why we shouldn't be looking for the same thing for cancer that we were able to do for COVID. And as well as that, we've changed a lot of the rules. So things we were told we couldn't do, we now know we can actually do. So why don't we keep on doing them then?
Brilliant. Thanks, Mark. Jeanette, I'm sure you've got some thoughts on this.
Yeah, and I think it's a really tricky one, because I absolutely agree with you, Mark. There is a huge amount of data out there collected routinely on cancer patients, but it isn't made available easily to interrogate it. It isn't linked up, so you don't follow the patient through the pathway. You talk about the patient here or there, you don't have that linkage. We collect data in different ways. We don't link it quickly. It eventually does get linked. So you talk about outcomes, lung cancer survival outcomes from 2017, 2018, but you don't talk about them in a timely fashion. And I think that's partly about one of the reasons why we had that in COVID was resource went to it. It was, there was a huge amount of resource invested in that. There's also a bit about we stopped doing everything else. And I think that initial wave, not since the initial wave, but we really stopped doing everything else. And I think we will be seeing the results of that for years to come in our cancer patients. So I think it's a bit about acknowledging that the data is there, but it's also encouraging the population to be willing to share it, because a lot of people are very reluctant to share the data, because we've made a big thing about what companies can do with data, what big companies can do with data, but actually we need to share data, but we need public to agree to that. And I do think in COVID, for example, remote consultations, I agree with you, they shouldn't be all there. There are times when you need to interact face to face, but they all take time. It's not that they suddenly take no time, but also you have to be very sparing of them. Yeah, you need to really target them in the right place.
Really, really useful and really helpful thoughts here. I think there's links here as well with some of Yosha's points around the use of real world evidence and some of the transformations that we're seeing there. Yosh, I wonder if you wanted to come in here.
Yeah, sure. And I think, it's a trend we've seen for a long time, but we've got the Innovative Drugs Fund within the UK. We've got the increasing use and desire to use, I should say, real world evidence by, the MHRA, by NICE, etc. across the pond. At the FDA, we're very busy towards the end of last year releasing a number of different guidance documents in terms of how we should be better using and real world evidence in submissions and things. Also worth reminding ourselves that actually cancer in the UK helped to forge the way with the Cancer Drugs Fund. So I think some of the mechanisms, the processes and the intent is there. I think some of the changes in attitude to what you can use when and how you can access it is slowly changing. So I hope that, we do see that continue to evolve quite quickly. And just a point also, we've spoken quite a lot about trials, and that's incredibly important. To bring those innovative therapies to patients who potentially would not get access to those. But it's all about continuing to pull that innovation through once it's on market. So once a therapy is post-authorization, let's make sure that we have an uptake in the UK that is a lot higher than what we've seen in the past, these slow and low uptake curves of innovative medicines. Our general standard of care needs to improve kind of across the board. So I hope, by using and empowering the system with real world evidence, we do see the benefit, and it becomes a lot more of a kind of evidence generated discussion.
Can I pop in, Eve? I'm sorry to Bigfoot, but I think the Cancer Drug Funds is an amazing thing for the UK because it has allowed that fast tracking of drugs. I think what it needs to, it's now got much more sensible in that the tests that you need, the targeted tests, were not part of the bundle initially, and they've now been bundled in. But I'm a clinical oncologist, and I would make a plea for radiotherapy. Radiotherapy cures more people than chemotherapy, fewer people than surgery, but it's a good curative treatment that's increasingly used, increasingly targeted, increasingly precise, and it's also quite cheap and very cost effective, but there is no equivalent CDF for radiotherapy. The Cancer Drug Funds is about drugs only. It's not about anti-cancer therapies. And I would make a plea to look at cancer in the round, including surgery. But we need to look at all of the therapies, and we need to look at that innovative way to support all of the therapies.
We've been banging on about this in relation to radiotherapy in Parliament a lot, and the government just, they irritate me.
I
will not respond to that, Chris.
Chris, as our resident politician on the panel, I think you've touched on perhaps a frustration, shall we say, that some of us in the cancer campaigning community feel from time to time. How do you see us overcoming some of these barriers? Obviously, we're seeing some political leadership today on cancer, which we haven't actually had for a while, given a lot of the power starting to move to some of the arm's length bodies. How do you see us moving forward here and landing the messages in the way that we need for the changes that we want to see in the system with to the people with the power who can make the difference?
Well, I start from an assumption that we didn't have a big enough NHS before COVID arrived. We were running it at 95 to 98% of capacity. January, February, March were always difficult because you had to expand. So sometimes things got cancelled or didn't happen. And now, and then when COVID comes along, it stretches the elastic so far that it can't go back into its original shape. So, I think that general practice is in a really difficult situation. We simply don't have anywhere near enough GPs. And for me, I'm absolutely certain that my life was saved by my GP when I turned up on my birthday with a dodgy mole on the back of my head, and he sent me off to the on an emergency cancer thing, was seen within 5 days. 5 days after that, they were cutting it out. And then there was the threat that it was going to take 6 weeks to get the results back. Even though the dermatologist, I remember saying to her, what's it like when she cut it out the first time? She said, well, it's quite thick. And I thought, oh God. Anyway, so, I want more GPs to be trained in dermatology or to be able to spot these things, because quite a lot get missed. But that's another stress on a system which I think is overloaded. I think we have got to decide as a nation that more of us are going to train to work in the NHS. More of us are going to pay more to pay for an NHS, which is roughly 125% of what it is today. And we are going to take more responsibility for our own healthcare, making better personal decisions for ourselves, including on eating and drinking and things like that. And that is a whole political debate. And there is one other thing, sorry, I should say. Sorry, I'm downloading on you as a patient, and I've still got another 7 years of PET CT scans and so on, but an MRI. But I can almost put a cannula in myself now. I can't, but I used to be really, really needle phobic, and I know it's not a needle, but anyway.
We've got a workforce shortage, Chris, we'll take it.
Can I practice on you first? Anyway, no, the point I was going to make was, Dr. Google is a really dangerous thing. And I think that the mixture of private sector, not particularly private sector, but voluntary sector in the mix, especially in cancer, is so important. For me, the best advice I got wasn't actually the NHS website. You know, when you get your diagnosis, it was from Melanoma Focus, from Cancer Research UK, and so on. Keeping all those websites up to date, I cannot tell you how important that is for patients. It's such an important part of it. And some people will trust the NHS more than they would trust a charity, but for some people it'd be the other way around. Right, I'll shut up.
You make an important point there, Chris, in relation to the charities and their critical role. And one of the things that worries me is that charities have been put under incredible pressure by the pandemic, both financial but also otherwise. And one of the things we did in the European Cancer Organization was actually make a plea for European support for the different charities, because they fulfill a role that governments should be performing but aren't. And I wouldn't change that, by the way. I think they do such a good job that if they switch it back to government, they do a worse job, to be perfectly frank. But we need to support them. So there needs to be ways. And I know we have done that somewhat. I'm involved with Cancer Focus Northern Ireland, for example, and there has been governmental support for that. But you know, it isn't really important. It's sort of an unseen part of that sort of cancer continuum and that cancer support that really needs to be supported and embellished and you know, looked at the value that it actually gives to the cancer patient particularly.
Can I chip in and say I absolutely agree, Mark? You know, that the charitable sector is a huge boon for our cancer patients, and I think it's an amazing extra added value that provides actually essential stuff, which I don't like that we rely on it, but I think it's great. I think, Chris, you're absolutely right about Dr. Google. He's my least favorite colleague, but I think we have to come out. I think we need to own this and say, well, actually, not all the information out there is good. Not all of it's great, and we need to maybe think about how we can talk about accrediting information sites, badging information sites, so that they get pushed up Google, or that when you tweet them, you can see that it has some scientific basis. Because, you know, I get a lot of patients who come in with a certain newspaper going, and what about this treatment? And you go, it's a lot of I don't mind that discussion, but it's about how we can get patients to be more informed about healthcare generally.
Just a thought, sorry to butt in, but there's the online harms bill about to go through Parliament. There's that may be an opportunity to put something in about, I mean, it's meant to be dealing with completely different things, but there is an online harm potentially here, which is if you know, somebody goes online, they look up melanoma and they think, oh, well, I'm going to die tomorrow because I'm looking at the results from Texas in 1975 without realizing that that's what it is or whatever. Yeah. Really? We should have a campaign. Cancer research need to get their thing together.
Well, we've just come up with our next campaign plan, so thanks for that idea, Chris, and thank you for all of those comments around the role of the charity sector. Obviously, as the representative here for Macmillan, it's really pleasing to hear your comments on that. Obviously, I would entirely agree. We have played and continue to play a critical role propping up the system and providing the support for people when they aren't getting it from the NHS or the care system. So I think that's a really important reflection. We've got a few minutes left, and I just want to perhaps finish with a point that Chris made, which I think is really important, that I'd like us to just spend a couple of minutes reflecting on. And that is this future of patient self-management. Chris, you talked about the importance of your GP and your experience. We know one of the practices from the pandemic that the government's very keen to continue with supporting is our virtual appointments, in reducing the number of follow-up appointments and increasing more and more that onus on the patient to manage their own care. I wonder if anyone had any reflections on that before we close, given that feels like another important direction of travel at the moment.
Can I speak a bit about that? And I think this is a really tricky one, because we do an awful lot of follow-up, and not much of it we have an evidence base that it impacts positively on patient survival. And I think one of the things I'd like to see is some real world evidence of what we do impacts for the patient, because I think it's that thing of you bringing patients, even virtually talking to patients, they have 2 days of anxiety, they have a short consultation, they don't ask what they want to ask, it's not at a time that's convenient to them, it's not when they're ill and then they struggle to get back into the system if they have a new symptom. I think we really need to rethink what follow-up is for, and how we can best support patients to access what they need when they need it. But also there is some value probably to continued imaging post-treatment for certain groups of people. We need to facilitate that. And we need to switch the capacity to doing what we've always done to what actually adds value to the patient and what adds value to the healthcare system, I think.
I would agree with Jeanette. I think there are some things we do that is questionable in relation to the evidence base. And I think it also goes back to the resource issue that we talked about earlier. If we can look at ways in which, for example, we use endoscopies only when we really need them, they can be incredibly effective, but also it deals with the capacity issue. And obviously we had to look at some of those things in relation to fit testing, for example, during the pandemic for colorectal. And so I do think we need to sort of re-look at this, because there may be things we're doing that we think make sense, but actually there's no evidence to say that they're giving us any extra information that we don't already have, and then use that sort of resource, move it to somewhere where we really do need it.
So yeah, I think it's about that trial thing. Trials are always about the fancy treatments, not always about the fancy treatments, but they're about advancing the treatment aspect of it. And trials looking at how we benefit people in follow-up, trials looking at what that is, that's not often something that's easy to attract funding for. And we need to change that paradigm, I think.
Thanks, Jeanette. I think Yosh and David were going to come in, so perhaps I'll come to David first and then Yosh.
I'll be quick on the time. I agree in the data side, and I think it's not just the follow-up, it's also through the pathway. Again, I'm going to reference it, but prehabilitation, for example, that's an area which I think can add a lot, but we need to collect data on the impact that could have on patients' fitness for treatment, and getting them ready for treatment and beyond as well. So it's just a quick point there, and then I'll hand over.
Yeah, I mean, I was going to agree with some of the others. I think, we've got to look across the care pathway, and talked about real world evidence. That's not just clinical endpoints. That is the full patient experience. I come back to one of the first things I said, we have to learn from every patient experience, and that goes across the journey. That's not just when they're sitting there taking one drug or something.
Brilliant, thank you. Well, I think if there's been one overarching theme that's come out so strongly from today's discussion, it is that focus on the patient and the patient experience. Thank you all so much for your contributions to today's discussion. That brings us to the end of our session, the special panel session for World Cancer Day. And a big thank you to all of our amazing panelists for your thoughts and sharing your experiences with us. If you'd like to join the discussion, then do follow Chamber on Twitter @ChamberVoice and use the hashtag Innovating Healthcare. You can also visit the Chamber website, www.chamberuk.com, or email chamber at info@chamberuk.com. Thank you, everybody. Enjoy the rest of your day.
Thank you.
Thanks very much.